Welcome, everybody, to HouseCall VR presents Dr. Korey DuBois, Sports Medicine. We are excited to be here and live in this auditorium, not only here, but also on the live stream. For those of you watching at home, watching on your mobile devices, make sure you put some comments down below. Any questions you may have, because this is interactive. It's going to be a Q&A session immediately following the talk. And then we have a special surprise for everybody here in the auditorium. So if you are in VR, if you're in Horizon Worlds, please feel free to join us. We're here in the events section. This is the HouseCall VR Auditorium. You can find it right under your events, under your wrist, or continue to watch us on this live stream and follow along. And again, drop those questions in the comments. So thank you all so much for joining us. I'm going to hand it over to Naviculara, who is our representative from HouseCall VR and our founder. So thank you so much. Please welcome Naviculara.
Hello, thank you. Thank you everyone for being here tonight, and we really appreciate it. Thank you in particular to Oculos for being our amazing host and making it all possible. So just wanted to thank you for being here. Also, I understand there was an update which is making things a little bit difficult for some people to get in. So if you're watching on the live stream at home and you didn't see it in the chat already, there was an update, so you might have to pop out of Horizon Update and then come back in again, and then you can join us. We were looking forward to having a really great lecture today. So this is pretty historic. This is the second public medical lecture in the metaverse, and we are very excited to welcome Dr. Korey DuBois. Dr. DuBois is a very well respected foot and ankle surgeon. He is a fellowship trained foot and ankle surgeon practicing in the state of Delaware. He is really just a wonderful addition to the state and a great clinician. And we are very lucky to have him here speaking to the HouseCall Auditorium and also to the wider audience. If you're interested in connecting with Dr. DuBois afterwards, why what I would say is you can find his contact information just behind you. There are doors to Brandywine Podiatry. So go check out Brandywine Podiatry. That's the practice where Dr. DuBois is in Delaware. And maybe one day, if you are close, you can meet him IRL. Okay, well, without further ado, I'd like to introduce Dr. DuBois. He's going to be doing a short 15-minute lecture on sports medicine and lateral ankle injuries, and then we'll have a little Q&A, and then the big surprise. So everybody throw some confetti for Dr. DuBois.
Well, thank you everybody for being here. This is a totally new experience for me, so it's pretty cool. And I appreciate the opportunity from HouseCall VR and everybody else who organized this to have the opportunity to speak to everybody today. So it's pretty neat. So I'm going to talk to you guys mostly about ankle sprains in athletes. And that's an experience that as humans, we all are aware of what that feels like. We know it when we see it. It's a basketball player that comes down on an opponent's foot. It's a running back that makes a sharp cut on an inverted foot, or it's the beach runner that loses their footing on uneven sand. Most of us have experienced an ankle sprain or will, especially if we're involved in any sort of athletics that involve cutting or quick movements or pivots. But though most of us humans have experienced it, it's actually a relatively unique phenomenon in the animal kingdom. It's our burden to bear. And the question is why? I'm a big disciple of paleoanthropologists, the scientists that study the evolution of the foot and ankle. There's only a handful of them in the world, but their work has really informed the way that I approach clinical medicine. And so I'm going to talk to you a little bit about why athletes and then just humans in general experience instability of the lateral ankle joint and injuries to the lateral ankle, and why it's a specific human experience. So our closest living relative is the chimpanzee. I think that we've all heard that, but they don't have an anterior talofibular ligament. And when I talk about the anterior talofibular ligament, I'm talking about the ligament here in the very front of the ankle. There's two. You'll notice one on the front and one on the side. The one on the front is the anterior, meaning front of the ankle, talofibular ligament. The talus is the ankle bone, and the fibula is the bone on the outside of the ankle. And then beside it is the calcaneofibular ligament. This is the ligament that runs from the fibula, the bone on the outside, down to your heel bone, the calcaneus. There is a third lateral ankle ligament that's called the posterior calcaneofibular ligament that's in the back that really doesn't have as much clinical bearing. But for our purposes today, these two ligaments are important. Like I said, chimpanzees don't have an anterior talofibular ligament, and so you have to ask yourself, why is that? Well, the ligament functions to stabilize or stiffen the ankle and the foot when walking on 2 feet. Most of us are aware that bipedalism is a relatively unique human experience. There are only 2 subsets of animals that routinely walk with a bipedal gait or on 2 feet. One would be the primates, of which we're a part of that family, and the other is birds. Birds have a different makeup in their skeletal structure of their foot than we do. Their foot is stiff. It's made up of a smaller number of bones. Much of their bones have fused together, but humans have 28 bones in their feet, and they're held together by a number of ligaments, and that results in a relatively flexible foot that needs to become stiff if we're going to walk efficiently and safely on 2 feet. So chimpanzees don't have an anterior talofibular ligament, which I'm going to refer to as the ATFL for now on. And why don't they have one? Well, it's much easier to climb trees if you don't have a very stiff foot. It's much easier to mobilize the way that chimpanzees need to mobilize, whereas humans need that stiff foot. So we evolved a thickened band of tissue on our lateral ankle to stiffen the foot during gait. But evolution is imperfect. And if you study evolution, you'll understand that it's driven by natural selection, or the selection of traits to allow us to succeed in our environment. And we like to think of evolution as helping build perfection, but in reality, it's helping build just good enough. And the anterior talofibular ligament really is an example of evolution being just good enough that we still have regular problems. Once the selection pressure is eliminated, there's no further optimization, and that gives us the lateral ankle ligament. Which brings us back to athletes, and perhaps why the lateral ankle ligaments are most often injured. Athletes can be wondrous to watch. They make the unnatural seem natural. Yesterday, Steph Curry, perhaps one of the most coordinated athletes of all time, won another NBA championship. Steph Curry was riddled with lateral ankle injuries during much of his career, especially at the beginning, and it almost derailed his career. And he's an example of a great athlete that's been sidelined by these injuries. So that's my background. I really do, my background belief of why this is a problem. I really think that it's a structure that has fit the purpose of bipedalism, but is challenged when stressed by athletic sports and events, especially on uneven ground or quick starts and stops, of which I'm not so sure we were evolved to do that on a regular basis. So what does the ATFL do? Well, it resists the anterior motion of the ankle from the tibia, and it resists plantar flexion. So I'm going to come over here and I'm going to try to use this model. I'm going to do my best here. So I have the foot here, and the ATFL has become detached. The motion that it's resisting is this motion right here in this direction. So when I check to see if somebody has an injury to this ligament, I am quite literally stressing them forward, their foot forward on their tibia, to evaluate how much laxity or give is available in this ankle. Okay? And so if you have an inversion injury, the ankle is bending forward, and you can imagine it's bending forward and in. The forward stress impacts the anterior talofibular ligament, and the inward stress impacts the calcaneofibular ligament, which is the second ligament on that side. If I have an injury, the first ligament that's usually injured is the ATFL. It either tears or attenuates or lengthens in the setting of injury. The second is the calcaneofibular ligament, and that's usually when there's a greater inversion force along with the downward and forward force. So those are more higher energy injuries, and they're the ones that often result in somewhat catastrophic injuries for the patient. Like I said, the posterior talofibular ligament is present, but it doesn't always cause, or it's very rarely injured, and that's based on the anatomy of the foot and ankle. It often is not stressed in the setting of injury. So what happens to these ligaments when they're injured? As I said earlier, they are somewhat elongated, meaning that they stretch. And when they stretch, they cannot be as tight. And when something is not as tight, it does not allow the foot to stiffen as much as it should. And again, that's the goal of these ligaments, is to stiffen the foot and allow for mobility with a strong, solid structure. So once injured, the body sends pro-inflammatory mediators down to the ankle, and that results in swelling, pain, bruising. You may even see this bruising as pooling of blood further down in the foot beyond just at the ankle. And you enter the inflammatory process of healing. That usually takes about 2 to 5 days. Those are the toughest days. The ankle is often very swollen. After that, it moves on to the rebuilding phase of healing, and then eventually to the maturation phase. But the total time of healing an injured ligament can be somewhere between 6 to 12 months. And so a lot of times these athletes have lingering symptoms. There's also other associated injuries that occur with high energy ankle sprains, and we'll discuss those later. So I showed you the provocative clinical examination where I try to force the ankle forward to assess to see if there's injury. But there are other ways to diagnose ankle injuries. Palpation or feeling of the ligament to be painful is an indicator. Often I get a lot of information from the patient's history. The patients know what they did. They come in and they tell you, I had an inversion ankle sprain. The real challenge is ruling out other injuries that are similar. Ankle fractures, high ankle sprains, peroneal tendon injuries, which are tendons that are on the outside of the ankle that also function to stabilize the ankle. Bifurcate ligament sprain, which is another ligament in the hind foot, but not the ankle. All of these can imitate ankle injuries, and I do see these from time to time, especially in high energy injuries. I use MRI and ultrasound to evaluate these patients. Sometimes these have more value for surgical planning. Generally, I can make a clinical diagnosis in most patients with x-rays. It's really important to know who you're dealing with. Some people are at higher risk of these injuries than others. Patients with a very high arch, for example, have a foot that predisposes them to inversion ankle sprains. They almost naturally turn inward when walking. And then other patients with ligamentous laxity, such as Ehlers-Danlos syndrome or other ligamentous laxity disorders, they have a higher risk of injury simply because they're just less naturally stable than a lot of the rest of us. How do we treat this? Well, initially, right off the field, RICE protocol: rest, ice, compression, and elevation of the ankle. And then physical therapy is then critical. We're really working to rebuild the ability of the person to know where their ankle joint is in space. And so one of the things that are injured when the ligament is injured are mechanoreceptors. Mechanoreceptors are small cellular processes that work to help alert you subconsciously to stress and injury and prevent you from turning your ankle. Patients who have ankle sprains often have more ankle sprains later, and that's not only because their stabilizers are injured and not as efficient, but also because they lose some ability of their mechanoreceptors to allow them to know when they're about to experience an injury. Some of us have come close to an ankle sprain, stepped off the curb, and sort of snapped their foot or ankle backwards quickly. That's an experience where the mechanoreceptor did its job appropriately. So how do we end up in the OR? Well, high energy, high grade injuries in athletes where they have a rupture, complete tear of one or both of the ligaments, and they need to return to sport quickly is a reason to end up in the OR, depending on how serious they are about their athletic career. And then chronic ankle instability. A number of patients, generally believed to be over 50% of people who experience a high-grade sprain, go on to chronic instability because the ligaments heal in an elongated state and therefore are not as efficient in stabilizing the ankle. These patients tend to have recurrent sprains or just a feeling of generalized instability, sometimes a fear that they're going to continue to have injuries, or chronic low-grade swelling, pain, tenderness, stiffness with activity, and they often end up needing to go to the OR. They only go to the OR if they failed physical therapy, immobilization, anti-inflammatories, and probably a small percentage end up there, but I would say it's maybe about 5 to 10% of people who have a severe sprain in my hands end up in the OR. So surgically, how do we treat the ankle? Well, I almost always perform an ankle arthroscopy. I take a small camera, somewhere between 2.7 millimeters and 4 millimeters, and insert it into the ankle joint and evaluate the ankle joint. From the inside of the ankle joint, I can actually see the medial and lateral ankle ligaments, and I can evaluate the health of the cartilage, and if there's any scarring or impinging tissues within the ankle joint itself. Sometimes when there's been an injury, the scar produced starts to impinge the ankle, and patients feel that with almost every step. And then I usually perform a lateral ankle stabilization. So I try to recreate these ankle ligaments that were injured. Uh, this is actually a relatively new procedure. It was first attempted in 1932. So we're really less than 100 years into history of trying to fix ankle injuries. In 1966, the procedure that we do most often, called the Broström procedure, was popularized by a Swedish surgeon with the last name of Broström. And his repair was primary, meaning he sutured the injured ankle ligament back to the origin on the fibula. Most surgeons do a modification of this procedure today, as I stated. I do this procedure as well. I borrow some adjacent tissue called the extensor retinaculum to help reinforce the repair. And then I use technology called suture anchors, which allow me to attach suture directly to the fibula, or the origin of this ligament, to pull these injured tissues tight up to the ankle and eliminate that laxity that has formed after the injury. And then a lot of times I use an artificial ligament, and that's gained a lot of popularity in the last 10 years. It's cutting the recovery time for patients. It's allowing them to get back onto the field earlier. That ligament runs from the fibula to the talus along the footprint, or the course, the natural course of the anterior talofibular ligament. And if severely injured, you can do this for the calcaneofibular ligament, or the ligament on the outside as well. Even with the new procedure, it really takes 3 to 6 months for patients with severe injuries to get back on the field and return to sport. Sometimes they're able to start early activity around 4 to 6 weeks after the surgery. But a lot of patients really take a couple of months before they feel comfortable, especially if they've had repetitive injuries in the past. And so that's the course of treatment. There's a lot to learn in this space, especially associated with the physiology of the ligament tissue itself. It's a collagen type tissue, and we're starting to develop new artificial ligaments that are collagen based, that essentially incorporate into a new ligament after time. And so I think that's sort of the exciting science moving forward, is moving away from more artificial repair with artificial ligaments to new regenerative ligaments that will help recreate a new ligament for these patients, and hopefully be as close to their original anatomy as possible. So, if you sprain your ankle, like I said, it's a human injury. It's a sprain's a human story. It's probably humanity fighting up against our evolutionary limits. It's to experience a trade-off on the advantages of being bipedal. It's a trade-off for an unstable ankle. Next time you come down on your ankle, you can curse natural selection for not being perfect, but only being good enough. And so it's a pretty cool thing to be able to treat every day, and I'm privileged to be able to do it. And so I'm happy to answer any questions about either the lateral ankle or other types of injuries if anybody has them. And I really appreciate the opportunity to be here today. Thank you.
Awesome. Thank you so much, Dr. Korey DuBois. We really appreciate you being here. We also appreciate you all in the chat today. So if you have questions, we do have a couple so far. We're going to reserve those and give people in the auditorium a chance to ask some questions. So if you'd like, line up to the microphone. When you get on the red circle, it should tell you you are now extended voice. So go ahead and line up to the red circle, line up behind that person speaking if you have a question, and then we'll get answers from Dr. DuBois. So thank you all so much. Keep submitting those questions in the chat, and we were going to pass it over here in the auditorium to E.M. Halsey. Don't forget, when you get up to the podium, to unmute and then go ahead and change your voice settings, and then you'll be all set.
Thank you, Carlos. Hey, thank you so much for being here, Dr. DuBois. That was a wonderful lecture. I have a question for you. You know, ankle sprains are very common, and I'm curious when someone gets an ankle sprain, sometimes they feel they don't need to see the doctor. When should an individual who sprains their ankle see a doctor? Because I would be concerned maybe there is a fracture and they need to stay off of the ankle.
Yeah, that's a great question. So the question is, when do we need to see a doctor if we have an ankle sprain? I think a lot of that really comes how well are you functioning after the injury? And so swelling, pain, and difficulty walking is your body's ability to tell you to get off of your foot because you have an injury, your structures need to heal. If you're able to walk or if you're able to use a brace and you just have a little bit of swelling and you've been there before, you may not need to go see a doctor. But if you're having persistent pain, swelling, or you're having any difficulty walking at all, then you definitely need to have an x-ray because like you said, there are a lot of imitators, one of them being ankle fractures, which are often operative injuries, but also fifth metatarsal base fractures, which is the bone on the outside of the foot. Let's see here. I just turned this over here. um, so, there are a number of injuries that do require more advanced care beyond the ankle sprain. But if you're able to walk and it's going away pretty quickly with rest, ice, elevation, compression, in that setting, you don't necessarily need to run to the nearest ED. So really have to trust your function.
Thank you.
Hello, I have a question. So, say you sprained your ankle, would you prefer a wrap or sports tape?
I would probably prefer a wrap just because the quality of sports tape is so variable. In general, a wrap is pretty standard. I'm thinking you're thinking like an ACE wrap, which is a compression wrap,
Yeah.
with, yeah. I think that would probably be better. It allows you to get compression, which the sports tape, it really depends on who's applying it and how well you apply it. If you get enough compression, and then also it can be applied unevenly, which the ACE wrap's just easier to use. So that would be my recommendation.
Okay, thank you.
Can you hear me?
Yes.
Okay. Just so happens I have an ankle injury. I got it in April actually, and I at first couldn't stand on it, but I'm able to stand on it. And yesterday was my first day back to work. First part of the day, I was fine, but towards the end, I started feeling a little aching. And then today, I had to go to work because my boss actually put me out for 2 weeks so I can rest it. But today started hurting again. But the thing is there's no swelling. There's no if you look at my foot, you'll think that nothing's wrong with it, but it's like on the inside. They gave me a brace to put on it, but I just can't get rid of it. It's like it was like in April. So how long does it take? They took an X-ray. They said it was no fracture, that it was just a bad sprain.
Yeah, I mean, a bad sprain can have some bad underlying problems. There's one type of injury called an osteochondral lesion, which is injury to the cartilage. And there's a lot of evidence that many of these ankle sprains have osteochondral lesions that we don't necessarily see on x ray. And so, patients that have persistent swelling or pain, they can be exclusive, um, that continue to have difficulty after the expected period of recovery with appropriate treatment, which includes immobilization, physical therapy, an MRI can become indicated. And I would say that, you should definitely go through your standard course of treatment and then see a physician if you're still having persistent pain. But sometimes there are injuries that can't be seen on x ray. And so it's possible that you could have more than what, just a bad sprain. And also, there are high ankle sprains that can easily be misdiagnosed, and those take a little bit longer. They tend to linger, they're challenging injuries to treat. And then the other thing is, once you've been resting, and now you're doing a lot more. And whenever you've been resting for a while and then start to become more active, your body has been at rest, and you're putting stress on those tissues that have been at rest. You're going to have a little bit of soreness. So I always tell patients, expect to be a little bit sore as you're progressing through your recovery cycle, especially when you make changes in either activity or in immobilization. So when you go from a boot to a brace, or a brace to a shoe, or walking to running, or being at home to working, you're going to have a little bit of soreness, and it may be a little tender, it may swell. And so it sounds like you could be experiencing some of that as well.
So will it? Can I just keep on going and it'll eventually, get better? Because I'm sure my boss is going to continue to let me work from home.
Sure. I mean, I think it sounds like you should maybe go for a second look with your physician at this point. It's difficult for me to say, obviously, because I can't assess your
Yeah,
ankle.
yeah,
But it sounds
yeah.
like it was April, it's been June. It takes 4 to 6 weeks for most things to heal, and sometimes they tend to linger a little bit longer. So you're not out of the realm of just a standard bad ankle sprain, not being all the way there yet. But at this point, I would say it's worth following up.
Awesome. Thank you for that question. Thank you to everyone here in the auditorium asking questions. We've got quite a few questions on the live stream. Please keep those questions coming. We're going to start asking some from the live stream. In the meantime, come on and line back up, and then I'll let you know when we can come back in for some live stream in auditorium questions. So for now, let's go to the live stream. Let's look down in the chat. Dr. Dubois, our first question: are you familiar with the Ottawa ankle rules, and what are your thoughts?
Yes. Yeah, I think that they're very useful. So, for the audience, the Ottawa ankle rules are a set of rules that are used by physicians to determine if a patient with an ankle sprain or just a hindfoot injury requires further evaluation, such as an x ray to evaluate for fracture. And it focuses on evaluating a number of anatomic structures to see if patients are painful at these sites, and if they are, they then go on to further evaluation. And it's designed to not waste medical resources and keep costs down, while also appropriately identifying these injuries and not missing injuries, which obviously doesn't do anybody any good. You don't want to miss an injury in the setting of trying to save money. So these rules have been developed and they're widely followed, and I also follow them myself.
Fantastic. Thank you so much for that. We have another question. Are there any common injuries that, if ignored, they can lead to long-term or irreparable damage?
Yes, so that's a very good question. One of the long-term sequelae of a severe ankle sprain or any injury that leads to instability is the development of post-traumatic arthritis. And so a lot of people are familiar with knee and hip arthritis, perhaps shoulder arthritis. Most of these arthritis experiences, if you will, for patients are the process of osteoarthritis or wear and tear. Whereas the ankle, although osteoarthritis does occur, is most commonly post-traumatic arthritis, meaning that a patient had an injury or repeated injuries that led to instability and damage to the ankle joint, and then slowly the development of arthritis in their ankle. And obviously, arthritis can be debilitating and requires sometimes relatively extreme treatment options. And so, a severe ankle injury, like I said earlier, can result in cartilage damage, and any cartilage damage can result in arthritis further down the road. And that's part of the reason why, a patient who has persistent swelling, pain, instability, inability to perform a lot of their desired athletic activities a couple months down the road may be good candidates for an MRI, because at that point you're looking for more occult injuries that you can't necessarily see on X-ray.
Wow, that's a lot of great advice all on that one package. So, thank you so much for that. So our next question from the chat, and again in the auditorium, if you have other questions, please line up, and we'll come right back to those here in the auditorium in Horizon Worlds. But back to the chat, we do have quite a few more questions. When does an individual need surgery to repair ligament damage?
Okay, good question. That is very important to discuss with your doctor. Surgery can be extremely challenging for the patient to undergo, especially foot and ankle surgery. I always tell my patients I want my elective surgery, and this is often somewhat elective, meaning it doesn't have to be done. I often want my elective surgery to be as unelective as possible. I want it to be as close as absolutely necessary as possible before we move further. So when I'm looking at somebody and saying you are a surgical patient, they're not able to do their activities of daily living, such as work, without pain. They're not able to perform their athletics without pain. They're not able to exercise without pain. Most of the time, this is why it ends up being athletes that I take to the operating room, because they're the ones that have high demand and the desire to return to sport or activity. And that can be as simple as walking the golf course, or as significant as I've had several high volume trail runners, and they get a lot of ankle sprains. And I've taken a few of them to the OR because they literally just could not get back to the hills. They could run on flat ground, but they couldn't get back to the hills. So, what makes a surgical patient? It's really a discussion between you and your doctor and your personal limitations due to your symptoms. If you have a complete rupture of either of your ligaments, it doesn't mean you have to have surgery. In fact, in most cases, I think a lot of those patients don't need to go on to surgery. It just depends on how you recover functionally and your day to day activities and what you're hoping to do and how much you're limited.
Awesome. Thank you so much. All right, let's take one more on the chat and then we'll come back into the auditorium. So, what is the typical treatment for a sprained ankle? Is it just ice? Is it heat? Is it relax? What would you recommend?
Sure. So I keep people away from heat because heat, although it may feel good, it increases blood flow to the area of the injury and that can increase swelling and inflammation. So my general protocol is quite literally the RICE protocol. It's rest, so eliminating the activity that's painful. It's ice, 20 minutes on, 20 minutes off the injured segment, as much as you can do it. It's compression, whether that's with an ACE wrap, or I often make a device called a soft cast, which is a combination of a couple of different wraps that we do in the office, and that does very well for people. It's immobilization, whether that's with a boot or a brace. It depends on how severe the injury is. And then it's elevation. So elevating the foot well above the heart when at rest, so on several pillows. Usually, like I said earlier, the first 3 to 5 days is the toughest. There's physiology that backs that up. That's the inflammatory phase. Once you get past that, things start to get a little bit better as long as you treat your body right and don't overdo it. So within 4 weeks, I expect most people to start feeling at least a little bit better unless they have a pretty severe injury or underlying occult injuries that are missed.
Awesome. Thank you so much. So, we're going to come back to the auditorium. So, please drop some more questions in the chat. Your questions are amazing so far. Thank you so much. Naviculara, go ahead and ask your question.
Hi. Thank you again, Dr. DuBois, for being here. It's such a pleasure to hear you speak on this topic. I've asked this question of our other presenter, and so I think that I feel great asking you today. If there was one thing that you wanted the audience to come away from this talk, whether it's treatment, prevention, anything along that spectrum, what would be the one sort of take home message that you would like for people to know from this talk?
Sure. Well, I know I spent a lot of time on it earlier, but I really can't stress enough the fact that this injury is a uniquely human injury, and it's something that we experience at a high volume. And because of that, there's a lot of money, effort, time, pain that goes into it. This really is one of those areas that receives a ton of attention, and it deserves it. And so, anything, if you're interested in treating these patients, evaluating these patients, being a part of their care, there's an opportunity for you to do that because we're going to continue to sprain our ankles forever. We could only hope to do better moving forward. It's a very, I probably haven't touched on physical therapy enough. Physical therapy is really the primary way of getting a lot of people back to their sport. And so the therapists deserve a lot of credit. And I can't, I think if there's one thing that I would tell people who have an injury that doesn't get better with just regular rest, ice, compression, elevation, immobilization, it's that therapy is really, really important. And if you skip that step and if you don't give it a full effort, you can expect that you may not get better. And I think that that's probably the primary message I have. This is not a perfect anatomic structure. I focus a lot on that for a reason. It is quite honestly imperfect, and that's why it's injured so often. And so it requires more effort to get better than a lot of other things. And so therapy is really critical in those patients that don't get better with just regular rest ice, compression, elevation, immobilization.
Awesome. Thank you. Thank you so much.
Yeah.
Thank you for that question, Naviculara. And again, if you have more questions in the chat, which we're going to start asking a few more that we still have, please leave those in the comments. And everyone else in the auditorium, please feel free. We do have a little bit more time for the Q&A, so step up to the microphone. Let's go to the chat for Dr. Dubois. Our next question comes from the chat. How do ballet dancers prevent constant injury?
So ballet dancers are a special type of patient. I have a handful. There is a professional ballet troupe in Wilmington, Delaware, where I treat patients. One, they're incredibly fit, and so that's one of the reasons that they do so well. They're very fit. Their day-to-day life, their job, whether they're students, which they generally take it very seriously, or professionals, is to be fit and stretch and to be active. And so the reason they're able to avoid injury is because of their lifestyle allows them to do it. They just really put a lot into their body, into being healthy and fit. I see a lot of dance injuries. It's generally overuse injuries. It's injuries to patients that have trained too far, have essentially overtrained, and that's not unique to ballet. You'll see that in any sport. I think it's becoming more common, especially in younger patients. I've seen, I'm a relatively young practitioner, but even in my time in training and now in early practice, I've seen more and more overuse injuries or overtraining injuries in younger kids who are specializing in a specific activity. When we were growing up, we played 3, 4 sports over 3, 4 seasons, and now we recognize that somebody has a talent for baseball, they're a great pitcher, and next thing you know, they're throwing way too many pitches, or they're a great ballet dancer, and instead of playing multiple sports, they're he or she is practicing ballet 6, 7, 8 hours a day, every day, all day. And I think that really leads to more injuries. And so I think we will see more overuse injuries and overtraining injuries as specialization becomes more and more common.
Fantastic. Thank you so much. So we're going to go again to the chat. And again, keep those questions coming. What are some tips for avoiding ankle injuries in kids?
So kids are pretty special. They actually have ligaments that are essentially stronger than their bones, and so they have a little bit of resiliency in comparison to adults. In general, to avoid injury, I would say recognize the kids who are at risk, and those are kids with high arched feet. Generally, those won't develop until they're a little bit older, um, you know, around puberty or higher, or kids that have a increased ligamentous laxity, so children with Ehlers-Danlos syndrome, things like that, they're at more risk. And then obviously, like, what kind of environment are they putting themselves into? Cheerleading, I see a lot of high energy ligamentous injuries in cheerleaders. And those can be pretty significant injuries. Often it's involved in patients who are doing throws or jumps. So it's more about the environment and the intrinsic part of the kid, but ultimately they have to get out there and do their activity. I wouldn't brace your kids just for the sake of it. They need to develop stronger muscles, bones, joints, and I wouldn't over immobilize them in their general day to day. I think that can only make their ankles and soft tissue weaker. So let them get out there and do their sports, and if they have an injury, you deal with it, and they heal remarkably well. Oculus, I think you're silent. I can't hear you.
Awesome. Thank you so much. So every time I see Thrive in the audience, I'm already ready to ask a question about our senior community. Thrive actually represents some of our senior community members, and this question is relevant to our aging community. So, what are some common foot and ankle injuries in the senior community? And are there any exercises to either strengthen or prevent these injuries from happening?
Sure. So, one of the most common things I see in senior people is loss of the fat pad of the forefoot or the hind foot. So, the front of the foot has a fat pad. When you get older, the fat goes away from the places you need it to the places you don't want it. And so, a lot of those patients start to have forefoot pain related to just less padding on the front of their foot. So, what can you do? Well, there are 4 layers of muscles on the bottom of your foot. And I think we have grossly underestimated the importance of those muscles. And I said earlier, I really, really look to the work by the paleoanthropologists in guiding my treatment and informing my treatment of patients. And those four muscles are initially meant for grasping and for actually doing work, for grasping trees, for grasping branches, and that's what we see in other primate species. But in humans, they just sit there and they get weaker as we get older. And so intrinsic muscle strengthening has a lot of value in elderly patients. And then just functional exercises, whether that's in the pool or whether that's walking or joining communities that allow you to exercise in groups, are all good for our senior adults. But I would really focus on intrinsic muscle strengthening. I'm going to plug a YouTube video that I tell a lot of my patients to go to. It's by I think he's a retired physical therapist named Frank, Frank, Ing, Ng, and he has a set of exercises that he uses for plantar fasciitis that I think are excellent. And I usually send a lot of my elderly patients that direction. And they can use YouTube, and they do a very good job. So Frank Ng, plantar fascia, those exercises are very good for anybody to do. They take 5 to 10 minutes, and they're well explained. And that's what I would advise. I think they're a good place to start.
So within horizon walking, maybe not so much without the leg and ankle bones, but in the real world, make sure you're getting lots of exercise and group exercises. Appreciate the advice. So we have one more question in the chat. Let's go to the auditorium first, since we have somebody in line, and then we'll wrap up with one question left in the chat, and then you have a special surprise for us after that. Can't wait to show everybody.
So, Dr. Dubois, you had mentioned this kind of goes a continuation of something you had mentioned about the children over immobilizing their ankles. I was an athletic trainer for quite some time, and we always tape the ankles of all of our athletes, no matter if they had an injury or not. What are your thoughts on that? I always feel that immobilizing too much, they're going to actually count on that and they'll actually get weaker over time rather than keeping their ankles strong and not needing the ankle taping. And you'll see that a lot even in professional sports like football.
Yeah, I 100% agree with you. I'm actually anti-immobilization unless you need it. And so, one of the things that are pretty popular in our field are orthotics or inserts in your shoe. And I am, I wouldn't say a pariah, but I have a opinion that's not very popular, and that's that most people don't need orthotics. And that's because I look at it as a low level immobilization or bracing. And whenever you brace or tape or whatever you do, you're going to make those structures weaker, like you're stating, and that opens you up for injury whenever you're not wearing them or using them. And so I think that orthotics in people who have foot pain or who are injured makes sense while they're having pain. But when they don't have pain, they should start to come out of those orthotics. Taping makes sense while you're injured, but when you're not injured, I don't think that you need tape, because you're just asking for further injury when you don't have the crutch of having that tape applied. So I agree 100%.
Thank you.
Awesome. Thank you so much. All right. So we have one more question in the chat. We're going to go ahead and ask that, and then we'll toss it back over to you to show us our surprise for the people here. And we're actually going to follow along at home with the live stream. So this question is I'm not sure if it's more of an opinion or a recommendation, but growing up, everybody's told drink lots of milk, makes your bones strong. And then there's some controversy over maybe it's just a milk campaign. It doesn't actually do anything for your bones that's significant if you drink more milk. So, is there any benefit, whether it's milk or other foods or drinks, that actually strengthen any bones or muscles in the foot or ankle, regardless of age, whether it's children or the aging community?
Yeah, I mean, you certainly need your required amounts of calcium and vitamin D, and vitamin D deficiency is super common. When I do surgery, I screen patients for vitamin D. I do a lot of diabetic limb salvage. There's some good evidence that in patients that have low vitamin D, there's a high risk of wounds not healing or healing not as efficiently. So I screen those patients as well quite often. One thing I would say is we know how bone gets stronger. There is a law. It's not really even a theory, it's a law called Wolff's Law that tells us that bone responds to load or exercise. And we all see that. And when you have an injury and somebody's in a cast for 6, 8, 10 weeks, sometimes you call it cast disease, but the muscles get weaker. The leg gets smaller, but the bone also gets weaker, and you'll see that there's decreased mineralization on X-ray. in patients that have been immobilized for a long period of time, and that's because they're not responding to load. And so, my answer to how do you strengthen your muscles, bones, joints? Is it milk? Is it nutrition? Well, nutrition certainly plays a part. It cannot be ignored, but more than anything, it's exercise and load bearing motion that's going to build pretty much everything in terms of connective tissue. In terms of connective tissue and building strength, motion and work is king. And so I would say just get out there and exercise.
Awesome. Thank you so much for that question. Thank you, everyone at home, for all of your questions. Appreciate you following along on this live stream. Make sure you like if you haven't already. Also, like and follow House Call VR. But we're not done yet. Dr. Dubois is going to go ahead and take us on the next surprise for everyone. So I don't know if you have a setup for that, or maybe this is it. But Dr. Dubois,
Yeah, sure. So the House Call VR was able to build an internal model of an ankle, which is pretty cool because we're going to be able to see what I see when we do an ankle arthroscopy. So I think the powers that be are going to take us there, and that's going to give us an opportunity to see what I see when I'm doing surgery on the ankle. And we can maybe answer a little more questions from that standpoint there, and people can understand what I'm looking for pathologically and how I can try and fix those things for patients.
wow, this is incredible. So apparently, we're going to have Dr. Dubois explain where we just went. But if you feel uncomfortable or you want to head back to the auditorium, to your right will be the door back downstairs. Otherwise, join us and enjoy Dr. Dubois. You may need to click that mic on and off again, and then you'll be good to go.
Can you guys hear me now? Okay, cool. Okay, so thanks for joining us inside the ankle joint. I appreciate House Call VR for building this for us. This is a very similar view to what I see when I perform an ankle arthroscopy. If you look around, you'll see in the distance names of the different segments of bones in the foot. Like I said, there are 28 bones. There's a lot, and we're sitting on top of the talus, which is the primary ankle bone. And if you look up, you're going to see the tibia. So we have the tibia above us, that's called the tibial plafond, and then below us we have the dome or the body of the talus. If you're facing out towards the rest of the foot and you look to the right, you're going to see the lateral aspect of the ankle, and if you look to your left, you're going to see the medial aspect of the ankle. Okay, and again, those ligaments sit on the inside and the outside of the ankle. When I do an arthroscopy, I'm looking from my viewpoint right here towards you guys. So I insert a camera from this side and I can look across the ankle joint. And what I'm looking for are injuries or damage to the cartilage. Some of you guys are standing on some spots. I see M. Holsey is standing on a spot. They've designed that to represent an osteochondral lesion or one of those cartilage lesions that we see sometimes in these lateral ankle injuries. We have some pretty cool ways of treating that nowadays. One of the things that we can do are debride or clean that up and then use donated cadaver cartilage mixed with platelet rich plasma or your own blood, plasma from your own blood, together to help try to heal that lesion into more normal cartilage. Cartilage healing is extremely difficult, and that's new technology, and we're seeing pretty good results with that. The fluid that you're seeing around you represents synovial fluid. That's the fluid that lubricates the ankle joints and all other joints of the ankle. That can actually become inflamed and can produce a material called synovitis. And when I do an ankle scope, I'll use a material or a tool to debride or remove some of that inflammation. And sometimes that can be what's causing the impingement or pain in the ankle joint. Um, if you guys would like, we could take a look at the outer aspect of the ankle. Let's see here. If I come this way. Yeah, if you guys want to follow me this way, we'll go over to where I would put the anchors in. I can explain that. Okay, so I'm waiting for everybody to get down from the very large ankle. Can you guys still hear me? Yes? Okay, great. So we're looking at a very large foot and ankle model here, and the reason we're on this side is we're able to see the fibula and then the labeled anterior talofibular ligament and calcaneofibular ligament, and those are the ligaments most commonly injured. I wanted to explain to you guys what we do when we do the reconstructive surgery, and this is the best view to do that. And so the origin of the ligament off of the fibula is often torn or injured. And so I use what's called a suture anchor, which is a device that enters into the bone and fuses essentially suture to the bone and allows me to bring that injured ankle ligament back to the fibula and make it taut and tight so that it can resist the laxity and stiffen the foot. I can do a similar maneuver for the calcaneofibular ligament as well, and that reduces that anterior and inversion translation that we see in patients that have instability. And this was the best view that we could get to show you sort of where those structures are located and how we could make an incision directly over that area and treat those ligaments and repair them primarily. Does anybody have any questions from this spot? I think I can answer the rest of the questions from here, potentially. Okay.
It looks like we don't have anything in the chat yet, so I guess continue on with the tour.
Okay, cool. All right, let's go back over to the other side. So we're going to return to the ankle and then we're going to go to the medial ankle. So you guys can just follow me this way. Okay. So the medial ankle doesn't get as much love as the lateral ankle, but it's often injured, and the injuries to the medial ankle can be, in some ways, even more challenging than injuries to the lateral ankle. And so the medial ankle ligament is called the deltoid ligament. You see it here. It's actually a large, broad band that courses from the medial malleolus, or the medial or inside aspect of the tibia, down to the heel bone, the ankle bone, and then the navicular, which is the bone just distal or just beyond the ankle bone. This ligament is stressed in patients with a flat foot, and you can imagine here as the foot rotates inwards with a flat foot that these ligaments become taut. And in our end-stage flat foot patients, it often becomes injured, and that can lead to pretty severe ankle arthritis. It's also often injured in ankle fractures. And I know we spoke a lot about the lateral ankle ligament, but this is not to be ignored. In a lot of patients who have ankle sprains that don't seem to get better, you always want to circle back and consider injury to the deltoid ligament or the inner ankle ligament because, one, it's very challenging to treat. It's in some ways a little bit more challenging to treat than the lateral ankle ligament. And then, two, it's ignored because it just doesn't happen as often. But if you have a patient with a flat foot, they're at increased risk of injury to this structure in comparison to a patient with a regular arched foot or a high arched foot. And so it's definitely a structure that we want to pay attention to. And you can see here it's on the inside of the ankle. So let's head back to the inside and then I'll answer any final questions. All right. So do we have any final questions or thoughts about the ankle or what we see when we perform ankle arthroscopy? What to expect if undergoing such a procedure?
So I do have the microphone. If anybody does want to take the microphone and ask a question here, perfect. Don't forget to unmute.
Should we go back to the auditorium? Or should I give the mic to somebody? I can, yes. 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 Yes, yes. Yes, so that's a really great question. So M. Halsey stated that sometimes she's seen patients or people that have an ankle sprain that also have pain up near the knee, especially on the outside. There is a variant of ankle injury called a Mason-New fracture, and a Mason-New fracture is a high fibula or ankle bone fracture that occurs in rotational or twisting ankle injuries, and that's actually an operative fracture in most cases. People who have a Mason-New injury need surgical stabilization. And so, if you have an injury, it's really critical to evaluate if you or if you're treating patients, if they have pain up near the knee on the outside, because that could potentially be a Mason-New injury and they need a tib fib x ray, not just an ankle x ray. And that certainly does get missed. It's often seen with instability of the medial or inside ankle ligaments, and those patients can go on to ankle arthritis if that's not identified. And so that's a very good point and good question, something that I neglected to speak about earlier, so I appreciate it. All right. Anything else?
Yeah, I'll pass the mic on over to Navicular for
Yes.
you.
Hi. Thank you. I just wanted to thank you again for being here and all of you for attending tonight's lecture. Again, thank you also for Oculus for hosting and live streaming. Feel free to stay in here and hang out. Thank you, Dr. Dubois. It was a really amazing lecture. You know, I've been practicing medicine for almost 20 years, and every time I hear you talk, I learn more. So it's just been really wonderful. Thank you so
Well,
very
I
much.
appreciate it. This is pretty cool. I was telling Arculos earlier. This is probably a new way of doing things. We did a lot of distance learning during the pandemic, and the thing about distance learning, not in this setting, is I can set my computer down and not be paying attention. But this really allows you to be present, and that's really neat. And I think a big opportunity here. It's definitely different talking not on a PowerPoint, and I think it allows me to be a little bit more present too. It's a little bit more challenging, but it's pretty cool too at the same time. So I appreciate the opportunity, and if anybody has questions, they can email me and stuff like that. So it's just my first and last name at gmail.com. All right. Thank you so much. I appreciate it.
Thank you. Thank you, everybody. Thank you. Give some thumbs up. Please like this world and also check out our other house call worlds. Also, you can get information about where to find Dr. Dubois, IRL, at Brandywine Podiatry. And if you go down to the auditorium, you'll see there is a door there to the Brandywine Podiatry world. That is one of the house call worlds. We have several of them. We have others in development, so stay tuned. Also, like and follow us and go check out some of our worlds and our games. We have a lot coming. And thank you. I'd like to thank Em Halsey, who is our anatomic modeler. She is right next to me. She is responsible for the anatomy that you see today. Also, over there hiding is Pigeon number 12, who is one of our amazing scripters. Thank you so much for being here. And then lastly, we're going to be publishing this ankle world with corrected anatomy. So just so you know, we made the anatomy a little bit simpler so that we had room to fit it into this world. But we're going to be correcting the anatomy so that it is proper, and we'll be publishing this world under the house call name. So thank you all so much. Here you go. Let me give it back to Carlos.
Awesome. Thank you all so much. I think we should end it off with a little bit of a fun. So, how about we race Dr. Dubois up to the tip of those phalanges? And for those at home who don't know phalanges, that big toe up there. How about it? Let's go. The view from the top of the foot looks amazing. Thank you all for joining us on this live stream. I'm Oculus 410. We're going to meet back down in the auditorium. Feel free to stream this again. This may have been a live stream, but this will be something available afterwards. You can watch this back from the beginning if for any reason you didn't actually get a chance to view it live in the first place. Check out HouseCall VR, as we mentioned. Make sure that you follow, like, subscribe, do all the things. Check it out on social media. If you want to check out Dr. Dubois, you can head on over to Brandywine as well, Podiatry. Naviculara, thank you so much for co-hosting. Thank you, Dr. Dubois, for hosting this amazing lecture. You can keep those questions going down in the chat below if you do have more questions. We appreciate you joining us. High five to everybody out there in Horizon. Thank you for those joining us live in the auditorium. And we'll see you on the next House Call VR stream. Good night, everybody.